This is Luis Sáenz, Cardiac EP, Director of the International Arrhythmia Center at Cardioinfantil Foundation in Bogota, Colombia, and President of LAHRS. I want to welcome you to this first live joint session, part of the academic program of the LAHRS 2020 scientific sessions. In this opportunity, we have organized a LAHRS-HRS joint session about update on clinical trials in AF with the participation of the PIs of the Cabana, Castle, and East trials. I want to thank to HRS for its participation, especially to Dr. Christine Albert, who is professor of cardiology and the founding chair of the Department of Cardiology at Cedars-Sinai Medical Center and president of Heart Rhythm Society. Christine will share with me this session. For the audience, please do not forget to chat your questions during the presentations that will be presented to the speakers at the end of the session for the discussion. Christine, welcome, and please introduce the session and our speakers.
Thank you so much, Luis. You've put together a fantastic session for us today on updates on clinical trials in AF and the possible impact on clinical practice. And we have three speakers that you all know. First, we're going to hear from Douglas Packer at the Mayo Clinic, and he's going to give us an update on Cabana. And then Nasir Marouche from Tulane will talk to us about Castle AF. And finally, but not least, Paulus Kirchhoff will talk to us about the recently published EAST trial. And you'll hear each presentation, and then we'll have a panel discussion afterwards.
Hello, I'm Doug Packer, and I'm delighted to be with you in the LAHRS sessions. It's been a great delight over the years to interact with you and to have you come to our meetings and have us come to your meetings, and it's a great opportunity to talk about Cabana. I'm going to give you some new information that you maybe have not seen yet, and we'll go through that and get an idea of just exactly where Cabana puts us. It puts us a lot further than we originally thought. This is my disclosure page. You've seen this before. This is advisory boards and funding and intellectual property. So when we presented this a couple of years ago, it was the Cabana trial, which means Cabana ablation versus antiarrhythmic drug therapy and atrial fibrillation. And there were a number of us involved with this, and I have to say a number of you were involved with this, and so we're very grateful to all those that participated in Cabana. We had 2,200 patients. 1,100 were ablated, about 1,100 underwent drug therapy. Now, if you look at the numbers ablated, 90% were actually ablated, 19% had to be ablated again, 9.2% were not ablated. These were patients that either changed their minds or their doctors changed their minds or they didn't have the funding for it. And we completed follow-up in about 1,000 patients over the course of 48 months. For drug therapy, it's almost identical. The difference is there were 301 patients who crossed over, and when they crossed over to ablation. Otherwise, it's quite a bit the same. And I have to say that it was very difficult at the beginning because there was a lot of arguments about what Cabana meant and what it said and what it didn't say. And this is something that comes from Princess Bride that I think most people in the world have seen. My name is Idaho Montoya. You peeled my father, prepare to fry. That was the argument. Well, then we got further into it, and we saw the demographics with ablation, 1,100 patients. The ages, less than 65 and about 34%, the same in drug therapy. 65 to 74 in about 50%. Greater than 75 and about 14%. You can see 37% were women. It turns out 42% were paroxysmal in both groups, and about 57% were persistent or long-standing persistent in both groups. So what Cabana shows you is it shows you a lot more about what was going on in persistence and long-standing persistent patients and patients with new onset atrial fibrillation that only had it for about a year, and they all were highly symptomatic. So here was the original finding. No difference. If you looked at the endpoint of death, disabling stroke, serious bleeding, or cardiac arrest, there was no difference by intention to treat. Maybe a little bit disappointing to begin with until we found out what it really meant. If you looked at the primary endpoint in subgroup analysis by intention to treat, there were patients under the age of 65, there were patients who were minorities, there were patients who had heart failure class greater than class 2, and there were other patients who actually did better if ablated than they did if they were not ablated. The rest was right pretty much on the line. Now, when we looked at primary and secondary outcomes by treatment received, so if you got ablated or not, it turned out that the primary outcomes were very different. In terms of event rate for ablation, 7%, for drug therapy, 10.9%. If you look at all-cause mortality, 4.4 versus 7.5, and you see that there's a fairly high significant difference in the hazard ratios, or someplace between 0.6 and 0.67. So that was actually quite a bit different when you actually looked at the patients who received treatment. If you looked at the primary endpoint, now you see in the KM curve that the ablation patients had fewer events, hazard ratio 0.73, drug patients more events. Now we looked at this, Peter Noseworthy did, and we did this in an observational study with the Optum Labs data. And the thing we found out was, did the trial participants represent patients in everyday practice? And could you, with observational data, help interpret the controversial trial findings? And what was the treatment effect in the excluded population? So now here, we're looking at overlapping weighted balance in patients on 90 different baseline characteristics. So we used 90 different characteristics to look at those together. And we used Cox proportion hazard regression, and the primary Cabana outcomes were used as before. 183,000 patients, 1,200 were ablated, 171,000 were not ablated. And you can see what the Cabana outcomes were as we've gone through so far. And the point that's important here is if you look at the Optum trial, then you see that there's a very big difference. And the ablation patients did much better in terms of their event rates. The drug therapy patients did much worse. So we found that if you looked at Cabana per protocol and Optum trial eligible patients, they're about the same. And the treatment received there, the hazard ratio is 0.67. And you can see that there was a larger absolute risk and absolute risk reduction in practice versus in the randomized clinical trial. Now, with trial designs and execution, you can be strict and purist. That's intention to treat. That's intentional. It's precise. If you're looking at data interpretation, it's pragmatic. It's practical. It's how we practice our therapies. It's as treated per protocol, and it's explanatory. It's not just exploratory. So let's look at AF recurrence. So this is done, and this is a paper that was done by Jean Poole. Ablation patients had much, much less in the way of recurrence. About 60% had no recurrence, about 40% did. Down here in drug therapy, about 60% did have a recurrence, and the hazard ratio is very, very different here. If you look at paroxysmal versus persistent and longstanding persistent, again, a significant difference between those in blue, that's drug. So the event rates were much higher, in this case, AF burden, than in patients who were treated with ablative therapy. Fairly different from what we thought to begin with. Now we'll look at quality of life. This is from Dan Mark's paper. We looked from 3 months to 60 months, and what we looked at was adjusted mean differences in ablation minus drug treatment. And so if you look at these from 30 months out to 60 months, it all favored ablation in terms of symptom relief and quality of life. Let's look at age. And, we're all less than 65, and so some of this applies to us and some of it doesn't. But if you look, those under 65 years of age, hazard ratio 0.53. Patients who were ablated did better than those who were drug treated. 65 to 75, about the same. Greater than 75 in terms of events, as noted. About the same to 24 months. And then ablation patients didn't quite do as well. And if you look at the hazard ratio and the interaction p-value is 0.07, which is what you'd expect for this kind of distribution. AF type. Well, 470 were paroxysmal, 524 were persistent, 114 were long-standing persistent, about the same as drug-treated patients. If you look at this in paroxysmals, ablation patients did very well, much, much better than drug patients. In persistent, the same. So now something that we've learned is that patients with persistent atrial fibrillation really did about as well as those with paroxysmal. And these are relatively new onsets, but not in long-standing persistent. With long-standing persistent, the ablation patients maybe didn't do quite as well. Interaction p-value here is null, which is what you'd expect when there's that kind of difference going from paroxysmal to persistent. Heart failure. Well, the thing that we found out about heart failure that I think is very, very important here is that in patients with heart failure, ablation patients fared much better, much less in the way of impact of events like mortality, disabling stroke, severe bleeding, or cardiac arrest, much better than those patients who were treated with drugs. Same thing if you look at the AF recurrence rate. If you look at the AF recurrence rate, you can see the patients with heart failure also did better if they were ablated than if they were not ablated. And the difference here is about 55 down to about 35. If you look at the MAFC score, and this is now looking at quality of life in heart failure, so Denmark did this, and you can see it's about the same. Catheter ablation patients did better in terms of quality of life for adjusted mean differences. Substantially better. Now, at the beginning, the patients were all pretty much the same. How about minorities? Well, the same thing. Ablation patients had fewer events in minorities than did drug patients. If you look at the primary endpoint, if you look at the secondary endpoint of total mortality, it's the same. Now, if we go through and look at mortality and minorities and non-minorities, you can see that the drug therapy patients didn't do as well as did the patients who were ablated in terms of event rates. If you look here in terms of drug versus ablation in non-minorities, not much of a difference, but a huge difference in patients that were or were not in ethnic groups. How about North America and Europe? Well, there's a little bit of a problem here. The hazard ratio for North America was 0.93. For Europe, it was 0.51. So in Europe, Asia, and Australia, patients did better. And this is even adjusting for a wide variety of different covariates. So does that mean that the people who are doing the ablation in Europe are smarter? Maybe. They may be better looking. Their kids may be smarter and they may be better looking. They may be richer. They may have more money. But at the end of the day, the North Americans did not do as well as others. How about the impact of sinus rhythm as we're coming to a close? If you look at drug therapy patients, and you look at how many had sinus rhythm at the end of the trial versus atrial fibrillation, fewer had sinus rhythm. More had atrial fibrillation. If you look in the ablation therapy, more had sinus rhythm. Fewer had atrial fibrillation. And if you make the comparison, it's 53% atrial fibrillation versus 47% in normal sinus rhythm. Now, you have to look at the way that comes out. The hazard ratio is 0.57. So the patients who had normal sinus rhythm had lower event rates than those who were in atrial fibrillation. How about progression and regression? Well, we found out that in ablation, there were 470 patients who were paroxysmal. What happened to them? Well, 26% stayed paroxysmal, 4% were persistent, 3% were long-standing persistent, but 67% were normal sinus rhythm. Drug therapy, it was different. Only 49% were still in sinus rhythm. So ablation did better than drug therapy did in terms of progression or regression. Here we're talking about regression. So there was a much greater regression in paroxysmal patients than there happened to be in drug-treated patients. How about long-standing persistent? About the same. Regression from long-standing persistent, where we think we do nothing, down to sinus rhythm in 53%, but only 26% were in sinus rhythm in drug treatment. So again, a substantial regression of event rates. And if you look at it all together with AF elimination, it's 64% in ablation, 48% in drug therapy. Effect size was 16% and significant. AF progression, only 7% in ablation, but 13% in patients who were drug treated. Again, minus 6% on the delta, highly significant. Here are the adverse event rates, and you can see what they look like. For the most part, the event rates were very, very low in both patient types. Nobody had an atrial esophageal fistula, but some had esophageal ulcers. There were patients, 3 that had TIAs. There were some that had strokes. There was a higher risk of stroke than simply a TIA. And if you look at both groups, then they're about the same. Now let's go a little bit further as we finish. So what does Cabana say about ablation? Well, it confirms the observational information and randomized clinical trials. 5 stars. It's an effective way of eliminating atrial fibrillation. 5 stars. Ablation is acceptably safe. 4 stars. It reduces mortality or cardiovascular hospitalization by intention to treat. 3 stars. It's effective in persistent AF and blocks progression better than drug therapy. 4 stars. It's highly effective as first-line therapy. This is new. So there's a number of things here that are new. First-line therapy. Ablation did not fare as well with intention to treat, but it did in treatment received in per protocol, particularly in heart failure patients, in patients of ethnic groups, and in patients who had ages less than 65 years. So we'll finish with how this is probably going to change our recommendations and guidelines. Persistent will probably go up to a 1A or maybe a 1B. If you look at patients with paroxysmal, if you go through catheter ablation, considered first-line therapy, that will probably go from a 2A up to a 1A. And then if you look at heart failure patients, it'll probably go up to a 2A or even a 1B. So I think these last 2 slides really are the outcomes. These are the ones that tell us what Cabana really says. We know this now after a couple of years that we didn't know before. And I hope that this is helpful in giving you an idea of what Cabana really tells us. And I just appreciate being with you. I wish I were down in South America with you. We're delighted as part of HRS to be part of Latin America, HRS. And I, again, am very appreciative of the invitation to be with you. So with that, we'll conclude, and I wish you the best for the rest of the meetings. Thank you.
Hi, everybody. Thank you for inviting me to the Latin America Heart Rhythm Society annual meeting. Honored to be back here. Unfortunately, I can't be with you in person, but hope next year, after the end of the pandemic, we get all together and give us hugs and celebrate the end of the pandemic. I was tasked to talk about CASTLE-AF, update new data I want to share with you today. ablation of AFib and heart failure. When I start with talking about challenges of antiarrhythmics, what we know about ablation of AFib and heart failure so far, and last but not least, as much as I'm impressed with the data we have in this patient population in favor of ablation, as I'm going to show you, we really need to be selective because there's no one-size-fits-all in medicine, never been. Let's start with antiarrhythmic drugs and challenges. We know this for years, not a new story for you. I like to show this slide again and again that we trying to use a drug like Ticussin, antiarrhythmic class 3 drug, against placebo in heart failure patients, and we failed to show any benefits in terms of mortality and outcome. The nail in the coffin, in my opinion, for rhythm control with rate control for heart failure population using antiarrhythmics was a rhythm control with rate control trial published in 2008. As you know, they compared the rhythm control strategy versus rate control strategy, but the rhythm control strategy applied amiodarone in a significant amount of patients in this study. And there's no difference in terms of worsening heart failure, stroke, and the composite of death, heart failure, or strokes. If you look at the sub-analysis of CASA-LAF trial, non-ablated patients using, in our study, Dr. Zhao from our research fellow, she is now in Shanghai. She looked at the patients who took antiarrhythmic for treating their AFib versus patients who took rate control, and these patients never been ablated during the study. And she found that there was, if you followed them more than 3.5 years, there was no effect using antiarrhythmics in terms of improving mortality, hospitalization, or the composite of both. Now, what we know about ablation so far in this patient population, AFib with heart failure or LV dysfunction, HFrEF patients plus AFib. CASA-LAF trial been reported a couple of times already, and you know about it a lot, but to briefly summarize, we took patient LV dysfunction, less than 35% EF, with ICDs and any kind of AFib practically. And we randomized them to antiarrhythmic, to rate control or rhythm control strategy using drugs, pharmacological treatment, or conventional treatment versus ablation. And we showed that we can reduce mortality with an ablation procedure with a relative risk reduction of 47%. We showed that we can improve admissions of heart failure by 45% reduction using an ablation procedure. The same thing for cardiovascular hospitalization, cardiovascular mortality as well. The ATTACK trial took patients with EF less than 40% HFrEF, but took amiodarone versus placebo or versus rate control strategy in this patient with non-arrhythmics versus ablation. I'm sorry, so amiodarone versus ablation, and it showed that not only they could improve EF in this patient population, quality of life, a 6-minute walks, but also in sub-analysis, they showed the death benefit or mortality benefits in favor of ablation and hospitalization benefit in favor of ablation when compared to amiodarone. Another reason to move on with the ablation procedure. If you follow the improvement, and this is data from CASA-LAF of EF over time, that's most of people do this procedure to achieve an improvement in EF. We could show a sustainability of this improvement of 5 years versus drugs, there's almost none. And this improvement has been shown in multiple studies in CASA-LAF, ATTACK, PAVA-CHF, CAMT-AF, and CAMERA-MRI trial. And the improvement varies between 8 to 18% after ablation procedure versus non-significant change in the drugs, pharmacological strategy, rate, or rhythm control. This is important. This is the work of Dr. Zones from CASA-LAF trial, where he showed that catheter ablation can improve the EF to more than 35% after an ablation procedure in 66% of patients. That's a big deal if you think about it, because you can ablate this patient before you put the device and watch this EF improvement, which happens usually short after, within 3 months, before you implant your ICD. That's a big deal. And this is a way more prominent or more significant compared to the ablation procedure or to the pharmacological arm treatment. Again, showing the slide from zones that this AF improvement is sustainable over time. And the burden relationship to this improvement wasn't that significant. So independent from the burden, improvement seems to be powerful. Dr. Cao is looking at the sub-analysis subgroups, how much burden we need. We look at extremes here, but there's some groups in the middle that could make a difference. But in general, this improvement after ablation to be sustainable and strong. Quality of life and symptoms have been shown for years now, and Dr. Kissler and his group, and Dr. Schilling as well, this is his work at CAMP-AF trial, where he showed after ablation, EF, heart failure symptoms and quality of life was associated with better improvement when compared to medical treatment. The same thing with CASTLE-AF. Dr. Sanders from Adelaide looked at sub-analysis of quality of life in CASTLE, and he showed significant improvement in favor of the ablation procedure. This is a study just published recently, and all of you probably will be talking about it now, the EASE-AF trial, which is, as you know, we compared rhythm control versus rate control, any strategy, drugs, ablation, and so on. What I want to highlight here that the people or the patients that profited the most from rhythm control strategy / ablation, if I can say, are the patients with severely depressed or more severe depressed LV function at 35% versus the patients with heart failure and more than 35% improvement, despite the fact both of them have significant improvement, as you can tell here, dots on the right side of the line, but these patients with the CASTLE-AF population did way better than others in terms of mortality and outcome. Having said all that, I pledge selection of the right patient for ablation procedure still today for multiple reasons. Yet, I wish I could say, separate everybody with LV dysfunction and AFib. It's not the case. We learned a lot from CASTLE. This is another paper from Zones who looked at New York Heart Class association with the outcome. And he showed that if you ablate patients with stage 1 and 2 New York Heart Class, you will report a better improvement in outcome compared with this population that's more severely impacted on arrival to the ablation procedure. The same thing for ischemics, non-ischemics. And this is not the only study. This is from CASTLE, that non-ischemics did better than ischemics in CASTLE. You can tell that had a ratio of 0.43. This has been shown as well in other studies. But before I go to that, I want to come back to the myopathy story. We are ablating AFib and arrhythmia, but there's a myopathy behind it, and we know that. We can't neglect it anymore. The tools are there to evaluate that. And this is a work we've been doing for years, and most of you know about this work, and you could be part of the CAF2 trial as we speak. But this is 4 stages of the myopathy. Green and white is myopathy fibrosis. So early stage of disease, later stage of disease. Why I'm showing all this? Because Dr. Akaya did look at this in terms of correlating this to outcome, improvement in LVF after ablation procedure. And what he could show that the improvement in ejection fraction detailed here, this is before ablation in blue, after ablation in red, you can see the improvement goes down with the amount of fibrosis. This is stage 1, this is stage 2, stage 3, and 4. Improvement goes down independent from the recurrent atrial fibrillation incidence and amount and burden. So myopathy seems to play a very important role. It doesn't have to surprise anybody listening to us today. The same thing was shown in a similar thing from the ventricular perspective, was shown by Dr. Kissler and his group in Australia. He looked at the enhancement of non-dilated cardiomyopathy patient, non-ischemic cardiomyopathy patient, non-ischemics. So the right cardiomyopathy patient, looked at the amount of scar in the ventricle. And he could correlate this amount of scar to improvement in EF. The more scar, the less improvement. And I can see from this slide, the cutoff of 15% seems to be a number to start with, to 20%. The burden story is just starting. I'm so happy to announce that this paper has been accepted and coming in publication as we speak from Dr. Brachman from the CASTLE-AF data, where we're showing the 50% burden or less improves mortality after procedure. So burden seems important to put in the equation. Higher burden is not good, lower burden is better. Dr. Belterson took the myopathy story as well and associated it with more AFib. He put loop recorders and he showed that the more fibrosis you have, the more AFib you see. So this myopathy seems to be the disease that we're dealing with, and we should be targeting and managing rather than the AFib itself only. All this data together, all these stories over the years, we developed this algorithm we use in our clinic, and in fact, this algorithm will be the foundation for the CASTLE-AF2 trial that we're planning. No high class 1 and 2 patients, we showed enough data. These patients should be ablated. If their LGE is in the ventricle, doesn't show much scar. If the scar in the ventricle is not that big, ablate them. And I said ablate them. Send them for atrial assessment of scar or fibrosis. If not that advanced, which is, by the way, this flow chart, the patient will be ablated about 65% of the patients. If the patient advanced myopathy, then you have to assess the need of that procedure. If you have advanced heart failure symptoms, treat them medically, improve the symptoms, and try to go through the protocol again. But again, be selective. We can't just take everybody with EF, with low EF and heart failure to ablation. Look at symptoms, look at scar, myopathy assessment, and go from there. I want to show this ESC guideline slide for heart failure patients. On the right side, you see the reduced LV function patients and AFib. And I'm so happy and proud on behalf of the CASTLE team and Johannes Bachmann and others that we could have a study that impacted guidelines. And you see the yellow color here, 2A indication for catheter ablation in patients with heart failure and low ejection fraction and atrial fibrillation. And the reason why is mentioned in this paper and that slide specifically because this CASTLE-AF showed improvement in mortality and others did. Now we can, after, in my opinion, after triaging our patient with imaging procedures to assess myopathy, we can triage them for an ablation procedure. Thank you so much for listening today, and I hope this summary of the AFib ablation in heart failure patient on the foundation of CASTLE help further guide you for 2 major messages. These patients do profit from an ablation procedure, and this effect seems to be sustainable. But not everybody profits from ablation procedure. We need to be selective. Thank you.
Hi, my name is Paulus Kirchhoff. I'm a professor of cardiovascular medicine and the director of the Department of Cardiology at the University Heart and Vascular Center UKE Hamburg. I'm also part-time affiliated with the University of Birmingham in the UK. This is a brilliant opportunity to talk to you about the findings of the early treatment of atrial fibrillation for stroke prevention EAST-AF-NET4 trial. As you've already heard in the prior talks in this session, rhythm control therapy has been evaluated repeatedly in the last few years, and I think we've come a long way. On behalf of all my co-authors and all the investigators of the trial and all the people who helped us deliver this trial, it's a distinct pleasure to tell you about the trial now. Why did we start the EAST-AF-NET4 trial? Even on optimal current management, patients with atrial fibrillation suffer stroke, acute coronary syndrome, heart failure, and cardiovascular death at a rate of approximately 5% per patient per year. Previous trials have failed to demonstrate superiority of rhythm control using antiarrhythmic drugs over rate control in patients with established atrial fibrillation. Antiarrhythmic drugs and AF ablation are safe in patients with atrial fibrillation and concomitant cardiovascular conditions. An earlier initiation of rhythm control therapy and the combination of antiarrhythmic drugs and AF ablation should maintain sinus rhythm more effectively than the current delayed approach to rhythm control. The early treatment of atrial fibrillation for stroke prevention trial therefore tested the following question. Does early rhythm control therapy improve outcomes compared to usual care in patients with early, recently diagnosed atrial fibrillation at risk of stroke? EAST-AF-NET4 is a multi-center investigator-initiated trial. The sponsor is the German Atrial Fibrillation Network, and the trial was supported by AFNet, BMBF, DHS, DZHK, ERA, Sanofi, and St. Jude Medical or Abbott. Patients at risk of cardiovascular events approximating a CHA2DS2-VASc score of 2 or more with recent onset atrial fibrillation, early atrial fibrillation defined as atrial fibrillation that was diagnosed less or equal than a year prior to enrollment, were randomized to either early rhythm control or to usual care. Usual care consisted of anticoagulation and rate control, supplemented by rhythm control only in symptomatic patients on optimal rate control therapy, as recommended by current guidelines. Early rhythm control therapy consisted of the same treatments plus systematic application of rhythm control therapy directly after randomization, either using antiarrhythmic drugs or AF ablation and cardioversion when needed. In case of recurrent AF, reablation or adaptation of antiarrhythmic drugs was performed. All patients received therapy of concomitant cardiovascular diseases. All patients had an in-person follow-up at 1 and 2 years, and all patients were followed up until the end of the study. EAST was designed to assess 2 primary outcomes. The first was a composite of cardiovascular death, stroke, worsening of heart failure, or acute coronary syndrome. The second was nights spent in hospital. The first primary outcome assesses complications of atrial fibrillation seen from the perspective of the patient. The second quantifies the burden to the healthcare system caused by atrial fibrillation management. It was deemed relevant that we would find a 20% reduction in the first primary outcome. And therefore, the trial was designed at an 80% power to detect a 20% improvement in the first primary outcome, requiring 685 events. 4% of the alpha was spent on the first primary outcome, 1% on the second primary outcome. An event review committee, blind to randomized group, centrally adjudicated all events, and sample size was initially estimated at 2,810 patients. In the end, as you'll see on the next slide, we enrolled 2,789 patients. 3 interim analyses were planned and conducted by the Data Safety Monitoring Board after accrual of 25%, 50%, and 75% of events with corresponding alpha spending. 2,789 patients were randomized in 135 sites in 11 countries. 1,395 patients to early rhythm control, 1,394 to usual care. All patients were included in the primary analysis as randomized. These are the baseline data. It's a very good picture of an average population with newly diagnosed atrial fibrillation. Mean age was 70 years, mean CHA2DS2-VASc score 3.4. Approximately a third of the patients, 29%, were in heart failure. Almost 40% of the patients were enrolled with their first episode of atrial fibrillation, and the median time between randomization and the first diagnosis of AF was 36 days. So really early atrial fibrillation. Furthermore, 30% of the patients were without AF-related symptoms at enrollment. Background therapy was excellent, with over 90% of patients anticoagulated, approximately 70% receiving antihypertensive or heart failure therapy. You'll see that patients randomized to usual care were treated with rate-controlling agents at an even higher rate, probably owing to the adaptation to the random group already. The same background therapy was maintained at excellent levels at 2 years, not shown here. Of the patients randomized to early rhythm control, 95% received rhythm control therapy consisting of either antiarrhythmic drugs or AF ablation, the latter in 8% after randomization. At 2 years, 65% were still on active rhythm control therapy, and at that point in time, 19% of patients had received AF ablation. In usual care, 96% of patients were managed without rhythm control initially. At 2 years, approximately 15%, so 1 in 7, had received rhythm control therapy, very much in line with what we see in general AF registries assessing rhythm control. Follow-up was excellent, and the median follow-up time in the trial was over 5 years. We only lost between 6.6 and 9% of the follow-up years, which is a high number compared to other large randomized trials, particularly strategy trials with a long follow-up duration. The usual care arm was managed according to current guidelines, whereby in the rhythm control is only indicated in patients who remain symptomatic on optimal rate control therapy. Whereas in the early therapy arm, all patients, as you've seen, 95% of patients received rhythm control therapy at the start. The trial was terminated at the third interim analysis due to efficacy. This plot shows you the funnel plot with the upper and lower limits of boundaries of termination. And you can see in blue, the observed hazard ratio is crossing the upper boundary at the third interim analysis. 249 of the 1,395 patients randomized to early therapy experienced a first primary outcome event, corresponding to 3.9% of patients per year. This was statistically significant at a p equals 0.005, lower than the 316 patients randomized to usual care who experienced the first primary outcome event, resulting in a 21% hazard reduction in patients randomized to early therapy. Each component of the first primary outcome was numerically lower in patients randomized to early rhythm control, including cardiovascular death and stroke, where the uncorrected 95% hazard ratio confidence interval did not cross the line of unity, and hospitalizations with worsening of heart failure and hospitalization with acute coronary syndrome. We performed a large subgroup analysis assessing 19 different subgroups, and we did not find any difference in the effectiveness of early rhythm control therapy in any of the subgroups, including in older patients or younger patients, obese patients or patients of normal weight, those with and without heart failure, those who were symptomatic or asymptomatic, and those with a high and low CHAD score. The second primary outcome was not different between groups. Patients randomized to early rhythm control spent on average 5.8 plus minus 22 nights per year in hospital. Patients randomized to usual care spent on average 5.1 plus minus 16 days in hospital. Early rhythm control was quite effective in maintaining sinus rhythm, resulting in 82% of patients being in sinus rhythm at the 2-year follow-up. This was clearly higher than the 60% of patients who were in sinus rhythm at the 2-year follow-up randomized to usual care. Of note, both usual care and early rhythm control were very effective in controlling AF-related symptoms. 3/4 of patients, 74 and 73%, were asymptomatic at the 2-year follow-up in both arms. There was no relevant difference in change in left ventricular function or in change in quality of life as measured by EQ5D or SF12. Also, we did not find a difference in cognitive function at 2 years between randomized groups. The safety outcome was not different between two arms. 231 patients had a primary safety event randomized to early rhythm control, and 223 of the patients randomized to usual care. We found numerically fewer strokes and fewer deaths in patients randomized to early rhythm control than in patients randomized to usual care. This was offset by numerically more patients who experienced a serious adverse events related to rhythm control therapy in those randomized to early rhythm control. Overall, the number of patients experiencing severe adverse events of rhythm control therapy was very low. We found only 10 out of the 1,395 patients who had an adverse event related to AF ablation, and only a bit over 20 patients with an adverse event related to antiarrhythmic drug therapy in early rhythm control. This was more than the 2 patients with a serious adverse event related to ablation and 8 patients with a serious adverse event related to rhythm control drugs in usual care. In conclusion, Early initiation of rhythm control therapy reduced cardiovascular outcomes in patients with early atrial fibrillation and cardiovascular conditions without affecting nights spent in hospital. As expected, the early rhythm control strategy was associated with more adverse events related to rhythm control therapy, but the overall safety of both treatment strategies was comparable. These results have the potential to inform the future use of rhythm control therapy, further improving the care of patients with early atrial fibrillation. We would like to thank all participating patients, the local study teams, the staff at AFNet and CRI, all committee members, and the financial supporters of the trial who committed almost a decade of their lives to completing this important study. We believe that we can draw the following final conclusion. Early rhythm control therapy should be offered to all patients with recently diagnosed atrial fibrillation and concomitant cardiovascular diseases, in addition to oral anticoagulation, rate control, and therapy of concomitant cardiovascular conditions. Thank you for your attention, and I look forward to the discussion.
Thank you very much to the speakers for the excellent presentations and for sharing this exciting data with us. Unfortunately, Dr. Packer got last time activities, reason why he's not going to attend this part of the session. And for his replacement, Dr. Jonathan Piccini will join us. Dr. Piccini is member of the Cabana investigators and is associate professor of medicine at Duke University Medical Center and the Duke Clinical Research Institute and director of the EP Clinical Trials Program and Arrhythmia Core Laboratory at Duke University. Welcome, Dr. Piccini, to this part of the session. As you know, we designed this module to know the last findings of the presented studies and also to discuss their possible impact on the clinical practice. So while Christine is identifying the question through the chat, I want to take advantage that you are not just researchers, but also physicians in practice to ask the next practical question for all of you. The clinical trials that you presented showed that catheter ablation is better to preserve the sinus rhythm when compared with drugs. Showed beneficial impact on quality of life and the composite of mortality or cardiovascular hospitalizations, decreased progression of AF with high safety profile. In fact, the last era AFib guidelines proposed catheter ablation as the first-line therapy for paroxysmal atrial fibrillation patients as a 2A indication. So my question for you is, how frequently do you use this indication in your clinical practice, and how do you individualize the indication to select the appropriate patients? So any one of you can answer.
Well, I mean, I'll just make a start, but I'm sure that Jonathan and Nasir will have their thoughts as well. To me, what the trials that we've just seen unanimously show is that rhythm control therapy is safe. And I think as an EP community, we have to communicate that very clearly to our colleagues who are general cardiologists or general physicians. Before we go into the debate, are antiarrhythmic drugs better than ablation? I think we have to sort of get rid of this old observation, this fear of the safety of rhythm control therapy that has stemmed from the CAST trial, that has been reinforced by the neutral result and the association of antiarrhythmic drug therapy with death in AFFIRM and other earlier rate versus rhythm trial. Whether you take MantraPath, Cabana, Castle-AF, East, rhythm control therapy is safe when you deliver it in the way that we know how to do it now. And to me, that includes antiarrhythmic drugs and AF ablation. And probably, to be honest, when we were all trainees, rhythm control therapy was probably less safe. So we've made progress there, and we see that in the trials. Now, with that said, I think we need to offer rhythm control therapy to everyone with newly diagnosed atrial fibrillation. And that is really what East AFNet shows. So You don't need to look at weight or symptoms or left atrial size or your favorite criterion to predict recurrence risk. Everyone, asymptomatic, heart failure or not, obese or not, old or young, with or without many risk factors, will benefit from rhythm control therapy. In our center, we have access to AF ablation readily, so we offer AF ablation as a first-line treatment. We know that not everyone wants it, and we know that antiarrhythmic drugs are a good first choice as well, so we offer that as well. But there are many other settings where catheter ablation is just limited because of the sheer amount of patients with AF. And therefore, I think, to me, the real step change that we have to communicate as a community to our colleagues is that rhythm control therapy is safe and it's beneficial. So it should be like anticoagulation 20 years ago, now offer it to everyone.
So thank you, Paulus. I'll give it to Johnson after me as well. I think if you put these three studies together that we just heard, it's clear, as Paulus said, that antiarrhythmic, Cabana showed you that antiarrhythmics and ablations are similar outcome. I mean, Doug is still showing some data about sub-analysis here and there, but the study showed antiarrhythmic drugs and ablation are the same. I mean, you can talk about crossovers, and the bottom line is, as Paulus said, antiarrhythmics are important in maintaining sinus rhythm in a healthy population. And this is the only thing where I disagree with Paulus on. EAST, the same thing. They showed antiarrhythmic drugs are safe and efficient in maintaining sinus rhythm. We cannot neglect these two studies back to back. We as an ablationist, and Doug stands up and that's his job as an ablationist, to promote the ablation arm of this. But fact is safe, ablation is safe, but don't forget antiarrhythmics work in these patients. That's fact, especially in early onset AFib. But in heart failure population, Paulus, I have to respectfully disagree a little bit there in terms of the studies so far. HFrEF, I'm not talking about HFpEF, I don't want to get that discussion yet. Public Council AF2, hopefully we show the HFpEF population more, but the HFrEF, antiarrhythmic drugs, AF-CHF trial, done in the past, it showed no difference, as you know, likely affirmed. But ablation has been coming up to be superior in that specific population. And that's important. And Louis' question is a clinician, what I do. HFrEF disease people, I would personalize the treatment. I would not ablate everybody. I have the imaging tools I use. I hope you can use your echo tools to look at strains and scarring and symptoms. New York Heart Class symptoms is important in this patient. But early stage today, after Paulo's data and Osama Wazni's data, by the way, from ESC as well, this top early AFib intervention in the cryoballoon data for early the outcome. If you put these two together, I think these guys need to be treated with the healthy hearts, and said AFib, I would treat them early, triage them based on the scarring and fibrosis and myopathy. But LV dysfunction patients as well, the same thing. I disagree on the use of antiarrhythmics in this population.
And to be fair, we don't know, sorry, Jonathan, I'm just jumping in because I think Nasir makes an important point. We haven't fully analyzed yet which group of patients received which rhythm control therapy. All we can say is that there were about 30% of patients with heart failure in EAST, and about 8% were treated with ablation as first line. So not everyone with heart failure received ablation, but of course that heart failure includes patient with an ejection fraction that is only moderately reduced. I think it's correct what Nasir says, that if you have access to AF ablation and you have a patient with newly diagnosed atrial fibrillation and HFrEF, AF ablation is a very reasonable first option.
And I think it's also important, sorry to interrupt you, John, but it's also important to notice the difference in the antiarrhythmic drugs that were used in EAST. I mean, it looked like you had a lot of 1C and a lot of dronedarone. And Nasir, the trials you were talking about generally did not use those types of drugs. So it will be interesting to see your analysis, sub-analysis of the antiarrhythmic drugs in EAST. Sorry, John.
No, I was just going to make two small points. That, we're all so involved in these data, sometimes we forget how dramatically different the evidence was 5 years ago. with AFFIRM and AFCHF, and really very few clinical trials looking at first-line strategies. And now we have multiple trials showing that ablation is superior as a first-line strategy, and a host of rhythm control strategies that demonstrate benefit. So I think that's one thing for us to remember, an important message for our referring physicians. The second thing is, it's really important to personalize from patient to patient. So I still think if you have a young patient with a normal size atrium who's a candidate for multiple medications and might do very well on flecainide for many years, so that when they do get their ablation, I'm sure the ablation we'll be delivering 5 years from now is better than the ablation we'll deliver today, as opposed to someone with heart failure who really is only a candidate for amiodarone or dofetilide, and maybe they have marginal renal function. That's obvious a patient who I think would benefit more from ablation. So I still think it's really important to personalize the therapy to our individual patients.
Okay. Dr. Kirchhoff, I have a question for you. You mentioned that no matter if the patient has symptomatic or asymptomatic LAS, left atrium sites, etc., we have to look for sinus rhythm on them, right? So based on that, on what could be done in asymptomatic patients that are on drugs and increasing progressively the burden of AFib despite of drugs, right? Because our catheter ablation procedure, the indication is mostly based on symptomatic patients, right? It's a kind of I don't know, a land that is undefined. What is your option, your clinical practice on these patients?
Now, I mean, this is to me the real paradigm change. I'm glad that you brought this up, Luis. EAST compared what we currently do, which is exactly what you described. We use rhythm control, including AF ablation in symptomatic patients, and we end up withholding rhythm control from 6 out of 7 patients with newly diagnosed AF. And that's what we saw in EAST. That's exactly what we see in large registries like ORBIT or EORP or PREFER. About 10 to 20% of patients in general AF registries receive rhythm control. 80 to 90% do not receive rhythm control. And now we know that it has clinical benefit. So I think we have to forget about symptoms. And this is a complete change to what we've done until August. And I know this sounds a bit harsh, and yes, you still need to treat each patient individually, but I think it's like anticoagulation now. You have to tell the patient, look, if you're not treated with rhythm control, this is only for people with recently diagnosed atrial fibrillation, right? Not for long-standing and then those who are called permanent AF. This is for newly diagnosed AF. It should be the third thing. You start anticoagulation, you start therapy of concomitant conditions, and everyone gets rhythm control. I'm sure that not everyone will want ablation. And I know this myself as a site investigator in EAST, particularly the asymptomatic ones, the ones that were diagnosed when they had a flu jab and came to their GP and then they suddenly had AF. They don't want an AF ablation because they don't know why. And then you treat them with an antiarrhythmic drug, and that's fine. And then when they have recurrence, you still have the ablation for later on, as John said. But I think we need to change that paradigm. We have to, this is no longer for symptoms. And you've seen in EAST that the current strategy of rhythm controlling only 1 in 7 patients renders them all asymptomatic. It's fine from a symptom perspective, but it's not fine from a stroke perspective. So okay. I think we need to treat everyone. It's a complete change of practice.
Sure. Christine, maybe you have some question from the chat?
Yeah. So there are a number of questions. So back to you, Paulus. There's been a couple of questions about the EAST trial. One was the TTR levels for Coumadin or the ratio of NOAC usage comparable between both groups in EAST, the treatment and the placebo?
So about 55% of patients received NOACs in EAST at enrollment, and that proportion increased slightly over the first 2 years of follow-up, and that was not different between groups. We had all 4 NOACs, and we also had all 4 vitamin K antagonists, because this was a trial done in Europe, so we used Well, I won't name them all, but fenprocommone, coumadin, fluindinol, warfarin, well, apixaban, edoxaban, rivaroxaban, and dabigatran. I think the key point is that the anticoagulation rate was very high, and that is probably one of the key differences to affirm. But there were no relevant differences between the way anticoagulation was delivered between therapy arms.
And then just one other follow-up question. When we had this discussion about antiarrhythmic drugs, I think somebody had a question about whether the majority of patients actually received antiarrhythmic drugs in that treatment arm. And I think the answer is yes, but
yes.
Maybe.
So I think it's important to point out that EAST was a strategy trial. And almost all patients, 95%, received rhythm control therapy at the start. 8% of patients received AF ablation. So that means that I have to calculate that now, 86% of patients, 87% of patients received antiarrhythmic drugs.
Yeah.
Most commonly sodium channel blockers, as you said. And we are working on this. I mean, we have only stopped the trial in March. This is less than 6 months after the stop of the trial and just 4 months after the last visit. So we are quite hectically busy, but we will try to describe all those details. Also, people who changed from one treatment to the other, and when did that happen, and what was the picture after 1 year and after 2 years. And I think these things will help us to understand how early rhythm control was delivered and how we can implement it in clinical practice. But I don't have the details now.
I have a question for Dr. Kirchhoff. I mean, in EAST trial, patients needed to send in the written control branch, needed to send EKG recordings, performing at least three times per week, as far as I remember, right? So that means that the follow-up was very intense, and actually the researchers needed to contact the patients each time that they recorded recurrences of atrial fibrillations. That seems to me that maybe the difference in the intensity of the follow-up and care it could explain the results in favor of the earlier rhythm control strategy. Are you agree on that? And how to get this kind of intensity in the follow-up? It sounds is key to get the same results, right?
So when we designed EAST, we thought that this telemetric ECG monitoring would be an important part to ensure that early rhythm control therapy is implemented. In reality, the impact of the telemetric monitoring on additional visits was very low. We have actually looked at that because this question has been asked a few times now. So the first thing to say is EAST was an investigator-initiated trial, and so we had few in-person visits. On average, in usual care, every patient had 1.8 in-person trial visits over the entire follow-up. One at 1 year and one at 2 years, and not everyone came. In the early therapy arm, we had on average 1.89 visits per patient. So there is an increase of 0.09 visits per patient induced with the telemetric ECG monitoring. Of course, I cannot rule out that this makes a huge difference in management, but I doubt it. So there are, I think it's around between 150 and 250 additional visits in the overall trial population over the 5-year follow-up that were induced by the telemetric ECG. So one thing that I think is fair to conclude is that this is not a big proportion of the intervention. We will analyze it further, but for those who are fans of digital health, I think it shows that at least in this setting, telemetric ECG monitoring didn't change management that much.
Now I have another question from the audience, and also I wanted to elaborate on it a little bit. So Nasir, you mentioned your protocol for picking patients with heart failure that you would choose for ablation. And can you describe sort of your clinic visit with somebody with heart failure and the steps that you go through? What is the ideal patient for an ablation with heart failure?
I mean, if a patient can come to the clinic, usually class 1 or 2, we called for a consult on the surface. We see the more advanced heart failure patient to treat their AFib. So patient come with the clinic and have EF of 30%, and we assess the symptoms if they are stable. New York class 1 or 2, we do an MRI scan. Obviously, we do this routinely now here at Tulane. We adopted the sequences have been implementing over the years, and you can, by the way, now you can use advanced echo imaging and look at strain and shape as well if you want to. There's some models here as well. But we do MR, and despite the defibrillators they have, and we assess the scarring. Direct cardiomyopathy and ischemic cardiomyopathy, we look at the scarring ventricle and the atrium. And based on that, we proceed as the protocol showed you. We see the patient back and we take them to the lab and ablate them. The challenge is the patient's highly symptomatic. You have to do something for them. And that's become a challenge. When you go to AFib, and then you have to take them and take the 10% success rate risk, knowing that the outcome would be not as good. That's a challenging patient population. Now, if I call to a patient who's advanced heart failure, we're working very closely with our team here in the heart failure team to fine-tune them first before we get them to the lab or the imaging protocol. So usually these patients have imaging on board. The heart failure patients have everything already done. And in Tulane now, standardized cardiac MR, and everybody, the heart failure patients get the floor, they get cardiac MR routinely now. So we know a lot about this patient advance, but symptoms seems to be a very important marker for outcome, not only in class LAF, beyond that as well, as you've seen in others. So we try to stabilize the patient within the lab, and then we look at the scar. We have a lot of scar in the ventricle, and what you're trying to achieve. If your patient's stable, try to fine-tune them, but the ablation will not help you much unless.
Do you use the MRI as well for the non-ischemics, and what about those patients?
Yeah, that's a population from camera MRI. It's non-ischemics.
Right.
It wasn't a population. We took non-ischemics and looked at the scar. If you have a lot of scar, then don't ablate them.
Okay.
Practically, they're saying that LV function does not improve as much. We have similar data actually from Brent Wilson, who's in Utah, published this a while ago. In our patient who we find scarring in them, called accidental scar, non-ischemics, and 11% of the population would have that kind of scar advanced already. And about 40% of the LV dysfunction patients have that scar. So look for advanced scarring, and usually they don't improve as much as others. All we're saying is, as you heard from my colleagues, personalize your treatment. You have the tools you have. Use them. It's not only age and young guy or old guy. I think we are beyond that now. We have the tools to look at that. The tools in your wrist, and we're implementing this as we speak. And this will be part of GOSSIP too, is pulse pressure curve behavior and how this impacts our outcome after ablation, before treatment, and triaging patients. So it'll be, as Paulo said, there's no way around these tools now to implement them into our treatment. So that's what we're doing. We know more about our patient. We're using drugs now safer than when I was in med school, and when we're not that old, Paulus, but still a while ago when we looked at that. So it's a changing field, but we try to fine-tune the patients before we treat them.
I have another comment. One of the big changes in the paradigm of especially of rhythm control therapy is about moving the binary definition of success, right? From this definition of absence of 30 seconds of atrial fibrillation recurrences to the measurement of AFib burden that may be a more real and maybe more meaningful outcome, right? So in the 3 studies, was the beneficial effect of catheter ablation on atrial fibrillation burden was stable along the study, along the follow-up of the study, and from the practical standpoint, how to measure AFib burden and how long time, as a clinicians, we have to follow those patients based on AFib burden. Anyone of us can start.
Maybe Jonathan, you could.
Yeah, Jonathan should say something. Yeah.
About from Cabana, because they have the most long term.
Yeah, I mean, I would say the two big two big takeaways on this point for Cabana is that the symptomatic improvement was maintained out to 5 years, and I'm not sure everyone expected to see that. And then the maintenance of sinus rhythm clearly conferred an advantage all the way into long-term follow-up. You saw Dr. Packer shared the AFib burden data, and there's AFib burden suppression or reduction across all the different types of AFib. So yes, both the symptomatic control and the control of AFib burden extended throughout the full 5 years of follow-up.
Okay.
I mean, we paper is coming out in JAC from Johannes Bachmann in AFib burden cluster. We finally got the paper out. It took us some time, but I think this is the first paper to, it's a hypothesis generating more that we found the burden, reduction in burden at bottom line after ablation is associated with outcome. It's clear message there because the cancer patient, we have the luxury to have continuous monitoring and we use that. Just download the ICD data in 6 months and that should be an indicator for how your patient would do. So just reducing the less than 50% that we found in Castle, you improve outcome of mortality and hospitalization. So that's a big message for all of us here. And the 30-second rule is over. Obviously, I consider it dead. And none of us on this call, I assume they use this in the practice. But more important is that we have the tools now, as I said before, to assess that. I mean, is it the wristband? Is this part of your day? Or you put a link or a reveal or some subcutaneous biomonitor in your patient. But we have the tools. We have so much tools we never had before. We had the clinic visit every 6 months, 12-week DCGs. Now we have all these tools. And we're using them, rightly using them the right way. And these studies, and I'm looking forward to see what Paulus have. And I know he didn't do a lot of long-term monitoring in his patients, but we have some group of patients who have long-term monitoring we can learn from. But burden is, I mean, it's no-brainer. Obviously now the subgroup of burden will come out, but it's over the times of 12, 30 seconds. It's dead, in my opinion.
Obviously, I can't tell you about subgroup data yet. What I can tell you is that we have about 300,000 telemetric ECGs, and they are being analyzed manually, reanalyzed as we speak. But I do want to sort of say two things, a bit of word of caution about AF burden. One, all the clinical benefits that we have seen in this session were obtained with the current technology of rhythm control. And this is not a cure. All of these patients had recurrent AF at some form. And if you implanted a link in all of the East or all of the, and if you look through all the loop recorder or the monitoring recordings from Castle AF, you'd find that a vast majority of patients will have some type of arrhythmia sometime. Now, whether that is AF is actually an interesting question. And we aren't even sure whether we should anticoagulate those patients when they have only very rare episodes. So I think there's almost a new disease entity that is emerging that is something that looks like AF but occurs only for 1 hour per year on a device. And the other thing that is challenging about AF burden is that it varies so much spontaneously. And that's why some of the early trials that used AF burden as a primary outcome actually failed. Mm-hmm. Trials like Mantra-PAF would have been completely neutral if they had used only AF burden as their primary outcome, even though time to recurrent AF or recurrent AF at 6 and 12 months showed a clear difference. And that is because everyone with intermittent paroxysmal AF, as we tend to call it, has periods in his or her life where they have a lot of AF and other periods where they don't have AF. So the variability is so high. A big study that's worth looking at in the field is anti-PAF or the GCAF data. And there's just so much variability, you don't find an effect unless you measure for decades. So I'm excited about the tools, and I think we'll learn a lot. And I mean, with technology moving on, and I've seen that Nasir is wearing a smartwatch, so many people will have one soon, and we will get that information, of course. But I think we'll have to deal with it with some caution, because we have to interpret it in a stochastic way, I think, not in a yes/no way.
So, do you have more questions?
No, I don't. I think I have
one for Nasir. seems that in the general community of clinicians, it is assumed that the benefit of catheter ablation for heart failure patients is just for those with high suspicions of presenting tachycardiomyopathy, and used to delay or refuse to indicate the ablation for heart failure patients when that suspicion is absent. So based on the characteristics of the population, including Castle AF, could you please clarify this important point about indication?
I mean, Castle AF took anybody. I mean, just look at and that's what we learned from randomized controlled trials. The patient population we dealt with tried to do sub-analysis to conclude here and there, but practically the inclusion of Castle, half-REF patient, you have to have 35% on EF or less. And you have to, and it doesn't matter what kind of ischemia you have, dilated cardiomyopathy or ischemic cardiomyopathy. We took both, any of those, including the study. And then New York Heart Class, we were New York Heart 3, and it's supposed to be 3 or less, but obviously we get the 4s in there. And you have to have an ICD, IV, dual chamber, as an inclusion criteria, because one of the patients already been treated for sudden cardiac death prevention, primary or secondary, and then any kind of AFib. That's important for Castle too, any kind of AFib. We have, as you know, on Castle, around 70% persistent, and the rest is paroxysmal. And the heart rate that we looked at, the rapid heart patient with a high heart rate, we're not finding a major difference in terms of outcomes. Probably the numbers weren't that high. But again, I don't want to make conclusion based on story about the RVR, rapid ventricular response causing tachycardia-mediated cardiomyopathy, as you call it. The Castle patient, we fine-tuned them 5 weeks before we randomized them into their treatment arm. They were fine-tuned for heart failure. We adjusted them, and then we to defer to both arms, and then we randomized them. So they were in a good shape after symptomatically. And there's actually a supplement, a nice intention to treat, a modified intention to treat 5 weeks later, how the heart failure was adjusted and the symptoms and so on. But going back to your question, we took any patient with heart failure and AFib, independent from the etiology, and we found that an ablation is superior to pharmacological management.
And I think, Luis, just to add to that, there were 30% of patients with heart failure in East, or 29%. So that is roughly 800, maybe 700. So that's double the size of Castle AF, just that sub-study, if you wish. And again, they were all treated. It was all types of heart failure. The only criterion was they had recently diagnosed AF. And that's actually the biggest change that we've seen in Hamburg, that our heart failure clinic teams talk to our EP teams on a daily basis now, when they have someone with newly diagnosed AF. And they don't
have to
management now. So I think that is, to me, again, it comes back to the main message, that is rhythm control therapy is safe and it has benefits, should be offered to everyone. And there are still many doubters out there, not in this panel, and probably not in this particular meeting, but there are still many doubters out there. And there are still so many patients that are just kept away from rhythm control therapy for historic reasons. And I think that is, to me, the key ceiling that we have to break.
What's a percentage of, we talk about heart failure, same thing with Cabana. What's a percentage of HFrEF in this heart failure? As you know, heart failure is not the same for everybody. So how many of them have LV dysfunction in East Polis?
Most of the patients had LV dysfunction, but it was also mild and moderate. The reason being that it's very difficult to diagnose HFpEF when you have atrial fibrillation, because the symptoms are the same, and then people say it's AF symptoms. There are some people with HFpEF, but not that many. I don't have the exact
You
number.
would say up to 700 patients, you will have 300 HFrEF, less than 35% at Castle population?
I would have to check the exact numbers, but there are well over 500 with reduced ejection fraction. Yeah. So that's an exciting sub-analysis to do.
Yeah, so great. I can't wait.
Okay. Jonathan, one question for you. We have a couple more minutes.
I'm going to have to I'm sorry, I have to go to another session. I thought this one ended at 1:15. Is it not? I apologize.
And it seems like Jonathan have a basketball game to go to too. I mean, I have to.
Okay.
No, it's a great
Looks like
session.
we-
I don't
looks like
want to.
we-
I just want to be able
It's like in
to.
stadium.
So please close the session, Christine. I forgot your compliments.
Oh, I'm
very
sorry. I'm sorry. I didn't mean to interrupt. Well, no, it's been a fantastic session. I mean, I think that, we have now 3 amazing big trials in atrial fibrillation, each of one that taught us something different and continues to teach us. The Cabana trial, clearly showed us that, atrial fibrillation ablation is helpful for symptoms, for burden, and in certain subgroups, it may be what we should be picking for first-line therapy. Younger people who potentially, are going to benefit perhaps more, patients with heart failure. And then it brings us to Nasir's work in CASTLE-HF, where we saw patients who had severe heart failure, who had failed drugs, and how much better they did from a mortality standpoint with ablation. And we heard about his new trial that he's going to propose with MRIs to try to stratify which heart failure patients benefit the most from ablation. And then finally, Paulus, your work is just starting to bloom for us. We're going to see that, it sort of breathed a little bit of light back into antiarrhythmic drug therapy, seeing that, the majority of those patients in EAST were treated with antiarrhythmic drug therapy. And you saw a benefit at 5 years on hard outcomes, including stroke, even though people were anticoagulated. So it makes us think, okay, maybe we should be a little bit more aggressive with patients. And again, it's tough, right? Because we've been doing this rate control first, especially with older patients with anticoagulation. So changing that paradigm is a huge paradigm shift. So I think more articles that you come out with for sub-analyses is really going to move the field forward for us to understand this a lot better. So I learned a ton during this section, Luis. I think you did an amazing job organizing. Thank you.
Thank you very much to all the speakers and you, Christine, and the Heart Rhythm Society for your help in organizing this session. Thank you very much to the attendance. Remember that this June session was recorded and will be available in the platform during 2 weeks. See you in the next modules tomorrow. Bye-bye. Take care. Thank you very much.
Bye-bye. Thank you.
Bye-bye. Bye.